Thank you, everybody, for your patience. So we will now move on to the Ebola session, and I'm so pleased to ask Dr. Wilbur Chen, who is chair of the Ebola Vaccines Work Group, to provide an introduction to us. Dr. Chen.
Yes, well, thank you for having me. Let's go to the next slide. So in May, I took over the responsibility of the work group chair, but I want to remind you that Dr. Sharon Fry served as the work group chair prior to my arrival. You'll notice that she continues to be a consultant on this work group. This work group is made up of a number of important stakeholder organization and subject matter experts that serve on this work group. So thank you for that. Next slide. And this work group is also supported by a number of CDC members. And I forgot to say on the last slide that our leadership is from Dr. Mary Choi. So we really appreciate her shepherding our group. Next slide. So I'll remind you that on December 19, 2019, the FDA approved Rvsd, I think is the correct pronunciation. And this is a replication-competent, live attenuated recombinant vesicular stomatitis virus vaccine, VSV vaccine, in which the glycoprotein of the Ebola Zaire virus is expressed. And February 26, 2020, the ACIP recommended pre-exposure vaccination among 3 recognized high-risk occupational groups. And they are, and you'll look at the 3 bullets, those who are responding to an Ebola virus disease outbreak, those working as healthcare personnel at federally designated Ebola treatment centers in the U.S., and this healthcare worker, this healthcare personnel is actually defined on another slide, slide 9 of this presentation. So I'll get back to that just briefly. But notice that this is federally designated Ebola treatment centers. And then the third bullet or area is that it's for persons who work as laboratorians or staff at biosafety level 4 facilities in the U.S. Next slide. So you'll notice perhaps the way that I read it, that there are perhaps some additional occupational risk groups that haven't been addressed. So in February of this year at the ACIP meeting, you heard the work group present on these 2 additional occupational risk groups, and they are healthcare personnel at state-designated Ebola treatment centers who are perhaps involved in the care and transport of suspected or confirmed Ebola virus disease patients. And then there are potentially individuals who work as laboratorians or support staff at laboratory research network facilities that handle specimens that may contain the replication-competent Ebola virus in the U.S. And so we presented the results of surveys of vaccine acceptability in these 2 populations at that time. Next slide. So although COVID kind of continues to occupy the minds of most of the world, Ebola does continue to be a major global health problem. So in February of this year, Ebola broke out in Guinea in West Africa, causing 23 cases and 12 deaths. Meanwhile, in the DRC in Central Africa, they experienced an outbreak of 12 cases and 6 deaths. And currently there's another outbreak that's ongoing. Now, as of October 8th, it started, and even just yesterday, there was an update that there have been 8 cases identified and 6 of those have resulted in deaths. Next slide. So the work group has continued to solicit input from the Council of State and Territorial Epidemiologists to really define, better understand these state-designated Ebola treatment centers. And we've discussed on the risks of exposure to Ebola virus for these 2 identified occupational risk groups. And we have had ongoing discussions with the proposed policy options that we're going to present today. Next slide. So our agenda is that Dr. Amy Whitesell will review the grade and the overview of what we understand for the state-designated Ebola treatment centers and the laboratory response network. Dr. Jason Malenfant will present to us the evidence to recommendations framework, and Dr. Caitlin Kosseboom will summarize our work group considerations and provide the policy options. Next slide. So this is the definition. It's also found elsewhere. This is just to remind you that we've carefully defined who these healthcare personnel are when we're talking in context of the state-designated Ebola treatment centers. Next slide. Thank you so much.
Thank you, Dr. Chen. We'll move on to Ms. Amy Whitesell, who will speak about the review of state-designated Ebola treatment centers and lab response network facilities. Please go ahead.
Great, thank you. Good afternoon, everyone. I'll be presenting additional background information on the ACIP Ebola vaccine virus work group's activities to date and the Rvsd Delta G BEBOV-GP Ebola vaccine, which I will refer to as the Rvsd vaccine moving forward in this presentation. The information in these slides will be referenced later in the evidence to recommend framework presentation and are included here to provide additional context. As a note, the data I will be presenting today have already been presented at previous ACIP meetings. Next slide, please. This slide provides an overview of the topics I will cover during this presentation. First, I will provide a brief summary of the critical outcomes related to the Rvsd Ebola vaccine that were assessed using the grading of recommendations, assessment, development, and evaluation, or GRADE approach. These data were previously presented during the February 2020 ACIP meeting. Next, I will provide an overview of state-designated Ebola treatment centers and will review results of a vaccine acceptability survey conducted among healthcare personnel at these facilities. And finally, I will provide an overview of the laboratory response network and present results from a vaccine acceptability survey conducted among laboratorians and support staff at these facilities. Results from the vaccine acceptability surveys were previously presented during the February 2021 ACIP meeting. Next slide, please. First, I will review the critical outcomes for the Rvsd vaccine evaluated by the GRADE approach. As mentioned, these data were originally presented during the February 2020 ACIP meeting. Next slide, please. For the February 2020 ACIP recommendations, the ACIP Ebola vaccine work group determined the PICO, or Population Intervention, Comparison, and Outcomes, which was as follows. The population of interest at the time was adults 18 years of age or older in the United States population who are at risk of occupational exposure to Ebola virus within the following three subgroups. 1, individuals responding to an outbreak of Ebola virus disease due to Ebola virus. 2, healthcare personnel involved in the care and transport of confirmed EDB patients at federally designated Ebola treatment centers in the United States. And 3, laboratorians and support staff working in biosafety level 4 laboratories that handle Ebola virus. The intervention of interest was pre-exposure intramuscular immunization with a single licensed dose of the Rvsd Ebola vaccine, and the comparison was no vaccine. The outcomes the work group considered critical or important are also listed here. Of note, there were 2 outcomes the work group considered important but not critical, which included the incidence and severity of oral or skin lesions. Data for these outcomes have not been analyzed to date and were not included in the GRADE evaluations presented in February 2020. For this presentation, we will focus on the critical outcomes that were subject to analysis on the next slide. Next slide, please. This slide lists the critical outcomes we assessed using the GRADE approach. The benefit outcome of development of Ebola-related symptomatic illness, and the safety outcomes of incidence and severity of arthralgia, incidence of arthritis, vaccine-related adverse pregnancy outcomes for women inadvertently vaccinated while pregnant, and women who become pregnant within 2 months of vaccination, detection of Rvsd vaccine virus in blood or plasma, saliva, and urine, which acted as a surrogate for transmissibility of vaccine virus, and serious adverse events related to vaccination. To assess these outcomes, we executed a literature search that resulted in the identification of 18 articles that presented data from 11 unique studies, which were included in qualitative synthesis. 9 of these articles, which presented data from 8 studies, were also included in quantitative synthesis, or meta-analysis. The first 4 outcomes listed on this slide were included in a meta-analysis, whereas outcomes 5 and 6 were included for descriptive analyses only. Next slide, please. To summarize an overview of the benefit outcomes that we reported during the February 2020 ACIP meeting, there was one published study with an unvaccinated comparator that was included in the body of evidence for this outcome, Rvsd 2017, which was the publication associated with the SASA-SEEK trial in Guinea. This was a 2-part phase 3 cluster randomized open label ring vaccination trial. The initial study involved contacts and contacts of contacts of confirmed Ebola virus disease or EVD cases that were randomized to either immediate or delayed vaccination. Delayed vaccination was defined as vaccination that occurred 21 days after randomization. A follow-up study included additional data about clusters who were offered immediate vaccination following cessation of the randomized trial. The primary outcome was the incidence of EVD with an onset of 10 days or more following randomization. The 10 days accounts for the average incubation period of Ebola, an unknown time for the vaccine to induce protective immunity. In this study, across 51 clusters randomized to receive immediate vaccination, which include 2,108 participants, no cases of EVD occurred 10 days or more after randomization. In contrast, across 47 clusters that were randomized to delayed vaccination, which include 3,075 participants, 16 cases within 7 clusters developed EVD 10 days or more after randomization. These randomized cluster data presented in the study equated to a calculated vaccine efficacy of 100%, with a confidence interval listed here. The calculated relative risk using the participant-level data from the randomized clusters was 0.04, which corresponds to a 96% relative risk reduction. And the absolute risk was 5 fewer events of Ebola-related symptomatic illness per 1,000 people. Next slide, please. Now I will provide a summary of the safety outcomes that were presented during the February 2020 ACIP meeting. The first safety outcome that I will review is the incidence of arthralgia. Incidence of arthralgia was assessed with the incidence of arthralgia or joint pain that was solicited within 0 to 42 days. 8 studies with unvaccinated comparators solicited arthralgia within 0 to 42 days and were evaluated by grades. It is important to note that across these studies, variable definitions for arthralgia were used, including joint pain with or without joint swelling or effusion, and in some cases, a definition was not provided. Additionally, length and time of follow-up and dose or plaque-forming units, or PFU, of vaccine used varied between studies. Across 6 randomized controlled trials, arthralgia was reported in 316 out of 1,874, or 16.9% of vaccinated participants, compared to 42 out of 891, or 4.7% of non-vaccinated participants. Taken together, the calculated risk from the 6 randomized controlled trials was 2.55, and the absolute risk was 73 more events of arthralgia per 1,000 people. Next slide, please. The next safety outcome that I will review is the severity of arthralgia. The severity of arthralgia was assessed with the incidence of severe or grade 3 arthralgia solicited between 0 to 42 days and defined as significant joint pain or discomfort that prevents daily activity. For background, arthralgia is described on a grade 1 to 4 scale, with grade 1 being mild, no interference with activity, grade 2 being moderate, some interference with activity, grade 3 being significant, prevents daily activity, and grade 4 being potentially life-threatening, medical consultation and/or hospitalization. There were no reports of grade 4 arthralgia across the body of evidence. 6 studies with unvaccinated comparators solicited arthralgia severity within 0 to 42 days. Again, it's important to note that across these studies, variable definitions for arthralgia were used, and the time of follow-up and dose or PFU of vaccine used varied between studies. Across 4 randomized controlled trials included in the body of evidence, 2 out of 333, or 0.6% of vaccinated participants reported grade 3 arthralgia compared to 0 out of 264 non-vaccinated participants. The calculated risk ratio from the 4 randomized controlled trials included in GRADE was 6.4, and the absolute risk was 0 more events of severe arthralgia per 1,000 people. Next slide, please. The next safety outcome that I will review is the incidence of arthritis, which was assessed with an event of arthritis reported within 5 to 56 days of follow-up. 6 studies with unvaccinated comparators elicited arthritis within 5 to 56 days. It is important to note that much like the arthralgia outcome, each of these studies defined and diagnosed arthritis with considerable variability. Additionally, time follow-up and dose or PFU of vaccine use varied between studies. Among the 4 randomized controlled trials, arthritis was reported in 39 out of 1,776, or 2.2%, of vaccinated participants compared to 16 out of 868, or 1.8%, of non-vaccinated participants. The calculated risk ratio across randomized controlled trials was 1.8, and the absolute risk was 23 more events of arthritis per 1,000 people. Additionally, 3 published studies reported on the detection of vaccine virus in synovial fluid. Across this body of evidence, vaccine virus has been detected by reverse transcriptase polymerase chain reaction, or RT-PCR, in 4 out of 7 vaccinated participants that had synovial fluid tested. Viral isolation was attempted on 1 synovial fluid specimen and was negative. Next slide, please. The next safety outcome I will review is vaccine-related adverse pregnancy outcomes for women inadvertently vaccinated while pregnant and women who become pregnant within 2 months of vaccination, which was assessed with incidence of pregnancy loss, defined as spontaneous abortion and stillbirth. There was 1 study included in the body of evidence for this outcome, which was a non-randomized sub-study of the Sierra Leone trial to induce a vaccine against Ebola. In this study, 14 out of 31, or 45%, of immediately vaccinated pregnant women experienced pregnancy loss, compared to 11 out of 33, or 33%, of unvaccinated pregnant women. The calculated risk ratio was 1.35, and the calculated absolute risk was 117 more events of pregnancy loss per 1,000 people. The study concluded that overall, the rate of pregnancy loss among pregnant women who received immediate vaccination was not significantly higher than the rate of pregnancy loss among unvaccinated women. Additionally, among live births, no external congenital anomalies were detected among either group. Further studies with larger sample sizes would be needed to rule out a meaningful difference in the percentage of pregnancy loss, pregnancy complications, or birth defects. Next slide, please. The next outcome I will review is the transmissibility of vaccine virus. There were no available data that reported on transmissibility. Therefore, detection of vaccine virus RNA in a vaccine recipient's blood, saliva, and urine by RT-PCR was used as a surrogate for the theoretical possibility of vaccine virus transmission. Data from 8 studies were included for the body of evidence for detection of Rvsd in blood or plasma. Across these 8 studies, the longest recorded RT-PCR positive blood sample was collected 14 days post-vaccination, when 1 out of 501 samples tested positive. Additionally, 1 study performed viral isolation on selected blood specimens, and all were negative. Data from 4 studies were included for the body of evidence for detection of Rvsd in urine and saliva. The longest recorded RT-PCR positive saliva sample was collected 14 days post-vaccination, when 1 out of 98 samples tested positive. The longest recorded RT-PCR positive urine sample was collected 7 days post-vaccination, when 2 out of 246 samples tested positive. Viral isolation was not attempted on saliva or urine samples. As previously mentioned, data related to oral and skin lesions, including the detection of Rvsd in skin vesicles, was not included in our February 2020 grades analysis, since the work group determined it to be an important but not critical outcome. And as mentioned, the work group limited our assessment of the transmissibility outcomes to detection of vaccine virus in blood, saliva, and urine. However, for today's presentation, we've included data from the FDA package insert related to skin vesicles for additional background. The longest recorded RT-PCR positive skin vesicle sample was collected 20 days post-vaccination. In one study, among 3 participants with rash, all were positive by RT-PCR up to 17 days post-vaccination. Virus isolation was positive in one specimen with the highest RNA level at 9 days post-vaccination. It is important to note with these data that the true estimate of duration of shedding is unknown because daily collection was not performed. Additionally, RT-PCR positivity is not synonymous with infectivity. Next slide, please. I will now review the final safety outcomes, which is vaccine-related serious adverse events, or SAEs. 12 clinical trials and 2 additional publications that describe use of the vaccine through expanded use mechanisms reported on vaccine-related serious adverse events. Across this body of evidence, out of 17,119 people that received the vaccine, 3 serious adverse events, or 0.02%, judged to be related to or possibly related to the vaccine, were reported. 2 of these were related to vaccination and included febrile reaction and anaphylaxis, both of which resolved without sequelae. 1 was judged to be possibly related to the vaccine, an influenza-like illness, which also resolved without sequelae. Additional data that was not included in our initial grade analysis included another case of anaphylaxis that was identified in data provided to the FDA and resolved without sequelae. In summary, the majority of studies did not report any vaccine-related SAEs. Next slide, please. This is the grade summary for the Rvsd Ebola vaccine compared to placebo or no vaccine in adults aged 18 and older. To provide context for interpretation, Type 1 or high certainty evidence means that we are very confident that the true effect was close to the estimate of effect. Type 2 or moderate certainty evidence means we are moderately confident in the effect estimate. Type 3 or low certainty evidence means our confidence in the effect estimate is limited. And type 4 or very low certainty evidence means we have very little confidence in the effect estimate. The overall evidence type for each outcome is determined by taking the lowest certainty value across both randomized controlled trials and observational studies for each outcome. As a reminder, we are not measuring how well the individual studies were conducted, but rather how much confidence we have in the estimates of effects from the body of evidence across each outcome. In summary, for the benefit outcome of preventing EBV, our findings were that the Rvsd Ebola vaccine is effective at preventing EBV. The randomized cluster level data for this outcome was assessed to be evidence type 3, low certainty evidence, while the participant level data for this outcome was assessed to be evidence type 2, moderate certainty evidence. For the safety outcome of incidence of arthralgia, our findings were that arthralgia is more commonly reported among vaccine recipients compared to placebo. This outcome was assessed to be evidence type 4, very low certainty evidence. For the safety outcome of severity of arthralgia, our findings were that severe or grade 3 arthralgia is more commonly reported among vaccine recipients compared to placebo or unvaccinated, but is overall uncommon. This outcome was assessed to be evidence type 4, very low certainty evidence. For the safety outcome of incidence of arthritis, our findings were that arthritis were more commonly reported among vaccine recipients compared to placebo. This outcome was assessed to be evidence type 4, very low certainty evidence. For the safety outcome of pregnancy-related adverse events due to vaccination, our findings were that the rate of pregnancy loss among pregnant women who received immediate vaccination was not significantly higher than the rate of pregnancy loss among unvaccinated pregnant women. This outcome was assessed to be evidence type 4, very low certainty evidence. For the safety outcome of transmissibility of vaccine virus, our findings were that the vaccine virus has been detected in blood or plasma in up to 14 days, in saliva up to 14 days, and in urine up to 7 days post-vaccination. However, true duration of shedding and potential for transmissibility is uncertain. This outcome was assessed to be evidence type 4, very low certainty evidence. For the safety outcome of vaccine-related serious adverse events, our findings were that the vaccine-related serious adverse events are uncommon occurrence, with 3 events in 17,119 vaccine recipients across 12 studies. This outcome was assessed to be evidence type 3, low certainty evidence. Next slide, please. That concludes the review of critical outcomes assessed with grade. Next, I will provide an overview of the population we will discuss in the evidence to recommend framework presentation, starting with state-designated Ebola treatment centers, and I will review results from the vaccine acceptability survey conducted among this population. Next slide, please. As Wilbur mentioned earlier, after the February 2020 recommendations were made, the ACIP Ebola vaccine work group identified 2 additional populations at potential risk for occupational exposure to Ebola virus. One of these being healthcare personnel at state-designated Ebola treatment centers who are involved in the care and transport of suspect or confirmed EDD patients. Next slide, please. In order to effectively discuss potential recommendations for this group, we first needed to define state-designated Ebola treatment centers, or ETCs. Following the importation of Ebola virus to the United States in 2014, certain hospitals were designated by states to serve as state-designated ETCs based on requirements set by the regional Ebola treatment network. However, this group has evolved over time, particularly as a result of the COVID-19 pandemic, and different terminology has been used to describe them. Therefore, we wanted to define this population in a way that would be evergreen and not subject to framework changes in the future. Since these facilities are designated by the states, we reached out to the Council of State and Territorial Epidemiologists, or CSTE, to determine the preferred terminology for these facilities and to define them moving forward. This resulted in CSTE convening a work group who determined that the preferred terminology for these facilities should be changed to Special Pathogen Treatment Centers, or SPTC. For the purposes of ACIP recommendations for the Rvsd Ebola vaccine, these Special Pathogen Treatment Centers have been defined as healthcare facilities that intend to receive and are able to provide care for a suspect or confirmed patient with Ebola virus disease for the duration of their illness, as assessed by their state health department. In addition to EDD, these facilities may also be designated by the states to treat other high-consequence pathogens. At this time, 55 special pathogen treatment centers have been identified, and it is currently estimated that each has a staff of 100 to 150 healthcare personnel. Thus, there are approximately 5,500 to 8,250 individuals at potential risk of occupational exposure to Ebola virus across the special pathogen treatment centers, who could potentially benefit from pre-exposure vaccination with the Rvsd Ebola vaccine. Next slide, please. Now I will review the vaccine acceptability survey results for special pathogen treatment centers, presented during the February 2021 ACIP meeting. At the time the survey was conducted, we had identified 51 special pathogen treatment centers and were able to send an invitation to participate in the survey to 49. We received 364 total survey responses. However, 66 were incomplete and excluded. Therefore, a total of 298 responses from special pathogen treatment center personnel were included in analyses. Next slide, please. Looking at the professional groups of the 298 survey respondents, nurses and doctors made up the majority, with 61% of the survey population self-identifying as a nurse or doctor. We have lower response rates from other professional groups, including respiratory therapists, EMTs, advanced practice providers, which included nurse practitioners and physician assistants, laboratory technicians, managers and safety officers, and environmental services. Next slide, please. When asked if they were eligible for vaccination and offered the Rvsd Ebola vaccine today, would they choose to be vaccinated? 54% of the survey respondents expressed interest in receiving the vaccine. It is important to note that responses to this question were recorded between October 2020 and January 2021. During this time, the Ebola outbreak in Equator Province, DRC, was declared over in November 2020. Therefore, responses were given as EVD cases were waning or when there was no active EVD outbreak in the world. Next slide, please. When we gave survey respondents the option of choosing when to get vaccinated, such as when an EVD case was imported into the United States or into their state, the interest in receiving the vaccine increased from 54% to 81%, while 19% of respondents would not choose to be vaccinated. Next slide, please. We also asked if they thought that ACIP should recommend the vaccine to healthcare personnel at their facility. 53% thought ACIP should recommend the vaccine, 9% thought ACIP should not recommend the vaccine, and 38% were unsure. Of note, we only asked whether or not the vaccine should be recommended, and the option of shared clinical decision-making was not included. Next slide, please. In summary, 54% of the study population was interested in receiving the vaccine at the time the survey was administered. But when given the option to get vaccinated at a later time, such as when there was an EVD case in the United States or in their state, interest in receiving the vaccine increased to 81%. When asked which adverse reactions they were most concerned about, concern for a serious adverse event and transmission of the vaccine virus to others were most common among the study population. Next slide, please. Finally, I will discuss the laboratory response network and review results from the vaccine acceptability survey among this population. The second population that the ACIP Ebola vaccine work group identified as having potential risk for occupational exposure to Ebola virus was individuals who work as laboratorians and support staff at laboratory response network facilities that handle replication-competent Ebola virus. Next slide, please. The Laboratory Response Network, or LRN, is a large network of laboratories that aim to quickly respond to biological and chemical threats and other public health emergencies. The LRN for Biological Threat Preparedness has 3 tiers that are depicted in the image on this slide. At the bottom tier, there are thousands of sentinel labs, largely in hospitals, clinical institutions, and commercial diagnostic laboratories that perform rule-out testing. In the middle tier, there are roughly 130 reference laboratories that are found in state and local health departments and at various military, veterinary, agricultural, and water testing facilities, and can do additional testing. At the top tier, there are 3 national labs, CDC, Submarine, and the Naval Medical Research Center. Within these 3 tiers, 58 facilities have Ebola virus testing capacity. We estimate that 10 to 15 laboratorians per facility would be capable of performing the test on a suspect Ebola virus sample. Thus, a potential recommendation would involve an estimated 580 to 870 individuals. Next slide, please. Now I will review the vaccine acceptability survey results for LRN facilities presented during the February 2021 ACIP meeting. The structure of the survey was the same as the one administered to the Special Pathogen Treatment Center. Survey invitations were sent out to facilities that had capacity for Ebola testing, which at the time was 62 possible labs. From these facilities, we received 96 total responses, 26 of which were incomplete. Therefore, 70 total responses were included in analysis. Next slide, please. The majority of respondents, or 64%, self-identified as laboratory scientists. 30% identified as management, and 4 individuals identified as other occupations. These 4 self-identified as either director or laboratory director. Next slide, please. 59% of the study population expressed interest in receiving the vaccine at the time of survey administration. It should be noted that this survey was administered from December 2020 to January 2021, so there was no active Ebola outbreak at the time of these responses. Next slide, please. Similar to the Special Pathogen Treatment Center participants, when LRN participants were given the option of choosing when to get vaccinated, either immediately when an EVD case was imported to the United States or when an EVD case was imported into their state, interest in receiving the vaccine increased to 86%. Next slide, please. Among this population, 59% said that they thought ACIP should recommend the vaccine. 9% thought that ACIP should not recommend the vaccine, and 33% were unsure. Next slide, please. In summary, 59% of LRN respondents would be interested in receiving the vaccine at the time of survey administration. This increased to 86% when they could choose when to be vaccinated. When asked which adverse reactions they would be most concerned about, most responded with the increased risk of arthritis, which differed from the Special Pathogen Treatment Center participants, or an increased risk of transmission of the vaccine virus to others. Next slide, please. This concludes the background presentation. Thank you for your attention.
Thank you. I think we're going to move on to the next presentation by Dr. Jason Malenfant. Dr. Malenfant, if you're on the line. I think you're presenting on the evidence to recommendations framework. No, am I looking
Yes, I'm here. Thank you.
Okay, thank you.
Good afternoon, everyone. Great to be here with you all. I'm going to be presenting on our evidence to recommendations. So specifically speaking about evidence for expansion of our recommendations for vaccination with the Ebola vaccine, which I'll also refer to as Rvsd throughout the presentation, for 2 new categories: special pathogens treatment centers and laboratory response network facilities here in the United States. Next slide, please. So the first policy question up for consideration is, should pre-exposure vaccination with the Rvsd vaccine be recommended for healthcare personnel involved in the care and transport of suspect or confirmed Ebola virus disease patients at special pathogens treatment centers? Next slide, please. The second policy question up for consideration is, should pre-exposure vaccination with the Rvsd vaccine be recommended for laboratorians and support staff at laboratory response network facilities that handle specimens that may contain replication-competent Ebola virus, species Zaire Ebola virus, in the United States? Next slide, please. The first question in the ETR framework is Ebola virus disease due to Ebola virus, species Zaire Ebola virus, a problem of public health importance? Next slide, please. So for this question, we considered the following. Ebola virus, species Zaire Ebola virus, is the most lethal of the 4 viruses that cause Ebola virus disease in humans. It is highly transmissible and found in all body fluids of an infected individual. It causes severe disease with rapid death usually occurring 7 to 10 days after symptom onset. And finally, in survivors, the virus has been known to persist in immunoprivileged sites and in some instances has resulted in continued disease transmission and disease recrudescence. Next slide, please. We know that the virus is a large international public health threat. Ebola virus species Zaire Ebola virus is responsible for the majority of reported EVD outbreaks, including the largest EVD outbreak in history, which was the 2014 West Africa outbreak. It has infected over 31,000 persons and resulted in greater than 12,000 deaths. Next slide, please. The virus is also a U.S. public health threat. 11 individuals infected with Ebola virus, species Zaire Ebola virus, have been treated in the United States. All were associated with the 2014 West Africa outbreak. 9 of the people were infected in West Africa, and 2 were infected in the United States while caring for a returned traveler. Additional persons have been repatriated to the U.S. following high-risk exposures to confirmed EVD patients, but none have developed EVD. Next slide, please. And so given all this information, is this virus a public health threat? Next slide, please. You would say, yes, it is. Next slide, please. The next section is related to benefits of the vaccine. The question is, how substantial are the desirable anticipated effects of vaccination? There was one study evaluated using grade that was just reviewed in the prior presentation that provided evidence on vaccine efficacy. This study at the participant level demonstrated a protective effect with a 96% risk reduction in vaccinated individuals against acquiring Ebola virus disease. Next slide, please. So given this, we feel that the desirable anticipated effects are large. Next slide, please. With regards to harms, the question is, how substantial are the undesirable anticipated effects? The data on adverse events were just presented in detail before this, but just to recap the main points. Arthralgia is more commonly reported among vaccine recipients. Severe arthralgia is also more commonly reported among vaccine recipients, but is overall uncommon. Arthritis is more commonly reported among vaccine recipients as well. Pregnancy loss in vaccinated women was not significantly higher than in non-vaccinated women. Additionally, Rvsd vaccine virus has been detected post-vaccination in blood, saliva, urine, and synovial fluid. And finally, vaccines-related serious adverse events are uncommon. Next slide, please. So for this question, overall, we graded these to be moderate. Next slide, please. The next question is, do the desirable effects outweigh the undesirable effects? To make this determination, we consider the following. There is documented protective efficacy of the vaccine. The virus causes high severity of illness. Ebola virus is also highly transmissible. Ebola virus has been shown to persist in survivors, and there are documented instances of continued disease transmission and disease recrudescence. And finally, vaccine-related SAEs are uncommon. Next slide, please. So based on all that, we felt it does favor intervention. Next slide, please. So now looking at the effectiveness of the intervention, we considered again this one study evaluated using the grade process that demonstrated a protective effect from vaccination. At the participant level in the study, the overall certainty in the evidence for effectiveness is moderate. At the cluster level, the overall certainty in the evidence for effectiveness is low. Next slide, please. So taking these into consideration, for this, we feel that in looking at the overall certainty of evidence for the effectiveness of the intervention is moderate. Next slide, please. With regards now to safety of the intervention, next slide, please. You've already just seen this table in the previous presentation with the various adverse events, and this is just here to reiterate the majority of these were evidence level 4s or very low certainty, with the exception of SAEs, which was level 3. Next slide, please. So we selected that the overall certainty of evidence with regards to safety was very low. Next slide, please. So now we will look at sentiments from our 2 target populations The first one being healthcare personnel at special pathogens treatment centers. And the first question we're examining is, does the target population feel that the desirable effects are large relative to the undesirable effects? Next slide, please. And again, looking at the data that was just previously presented, we know that 54% of the study population expressed interest in receiving the vaccine if eligible and offered the vaccine today. Also, when people were given the choice to get vaccinated at different time points, for example, when there was an EVD case in the US or their state, interest in the vaccine increased to 81%. And finally, 53% of the survey population thought that ACIP should vote to recommend the vaccine to healthcare personnel at special pathogens treatment centers. So to answer the question, does this target population feel that the desirable effects are large relative to the undesirable effects? Next slide, please. Based on the responses, we selected probably yes. Next slide, please. The next question is there important uncertainty about or variability in how much people valued the main outcomes? We considered for this that there were mixed responses to vaccination. When asked if they would get the vaccine today, 54% of the participants expressed interest. When participants were given the option of choosing when to get vaccinated, either immediately or when an EVD case was imported to the US or their state, the interest in receiving the vaccine increased to 81%. So when the perceived risk seemed to increase and there was flexibility in when to get the vaccine, acceptability also increased. Next slide, please. Given this potential and variability we saw, we selected there was possibly important uncertainty or variability. Next slide, please. The next question is this intervention acceptable to key stakeholders? Next slide, please. Again, we looked at the response that 53% of the survey population thought that ACIP should vote to recommend the vaccine to healthcare personnel at special pathogens treatment centers. And so to answer this question, next slide, please, we selected probably yes. Next slide, please. So now to get to our second target population, which is staff at LRN facilities, going back to the first question, does the target population feel that the desirable effects are large relative to the undesirable effects? Next slide, please. So just to again give highlights from the survey responses, and these were actually relatively similar results to the responses we received from healthcare personnel at special pathogens treatment centers. 59% of the study population expressed interest in receiving the vaccine if eligible and offered the vaccine today. When people were given the choice to get vaccinated at different time points, so again, for example, when there was an EVD case in the US or their state, interest in the vaccine increased to 86%. And finally, 59% of the survey population thought that ACIP should vote to recommend the vaccine to staff at LRN facilities. So coming back to the question, does the target population feel that the desirable effects are large relative to undesirable effects? Next slide, please. Based on the responses, we selected probably yes. Next slide, please. The next question is there important uncertainty about or variability in how much people value the main outcomes? So similar to the healthcare personnel at special pathogens treatment centers, we consider for this that there were mixed responses to vaccination. When asked if they would get the vaccine today, 59% of participants expressed interest. But when they were given the option of choosing when to get vaccinated, either immediately or when an EVD case was imported to the US or their state, the interest in receiving the vaccine increased to 86%. So when the perceived risk seemed to increase and there was flexibility in when to get the vaccine, again, we see here that acceptability also increased. Next slide, please. So similarly, given this potential and variability we saw, we selected possibly important uncertainty or variability. Next slide, please. The next question is this intervention acceptable to key stakeholders? Slide, please. And similar to our answer for the first group, based on the response at this time, 59% of the survey population thought that ACIP should vote to recommend the vaccine to staff at LRNs. To answer this question, next slide, please, we selected probably yes. Next slide, please. The next question is in regards to resource allocation. The question is the intervention a reasonable and efficient allocation of resources? A cost-effectiveness analysis was not performed for this vaccine, as it is intended for use in preparedness scenarios in limited populations and not as a routine vaccination in the general population. And at this time, the vaccine will be stored and made available through the US government. Next slide, please. So to answer this question, we said yes, it is a reasonable and efficient allocation of resources. Next slide, please. The next question is in regards to health equity. And the question is, what would be the impact on health equity? For this question, we unfortunately do not have a great sense of this, as in our surveys that were distributed out to the facilities, the only demographic factors collected were age, sex, and profession of the individual. There were no race or ethnicity data collected that would give us a better sense to comment on this question. Next slide, please. So to answer this question, we selected don't know. Next slide, please. The next topic is around feasibility. And the question is the intervention feasible to implement? So currently, licensed doses are available through the Strategic National Stockpile. Next slide, please. So we selected yes, the intervention is feasible to implement. Next slide, please. And now is the balance of consequences. So given everything we've just discussed thus far and putting it all together, for determining the balance of consequences, we selected that for both populations, the desirable consequences probably outweigh the undesirable consequences in most settings. Next slide, please. The final question is in regard to sufficiency of information. The question is there sufficient information to move forward with a recommendation? To make this determination, we considered that we do have available efficacy data in outbreak settings that do show high efficacy. We also have safety data for the over 17,000 persons that have been vaccinated in the US, Europe, and Africa that we evaluated using the grade process. And finally, we also have data from our vaccine acceptability surveys from both target populations under consideration. Next slide, please. And so to answer the question, is there sufficient information to move forward with a recommendation? We said yes. Next slide, please. Just again, providing the definition of healthcare personnel. Next slide, please. Next slide, please. Thank you very much.
Thank you for your presentation. I believe at this point, we will open up the session for questions. Is that correct, Dr. Choi? Yes. Okay. We are happy to entertain any questions from the committee. Dr. Paling.
Thank you for this presentation presentations and how clearly it was presented. The question that I have is the thought that this is a recommendation or is it a shared decision making? I'd really like to understand the work group's discussion about that point.
I'm going to repeat the question. So is it a recommendation or shared clinical decision making? And just to be clear, Dr. Choi will be calling on her team members as needed.
Yes, thank you for that question. We do have a policy options presentation that is going to come after, but the work group did meet and discuss what should be the proposal for ACIP today, and for both populations, we are proposing a recommendation. Thank you.
Dr. Talbot?
Yeah, and part of my confusion, I feel like I should know this. We're talking about this vaccine because it was licensed in the U.S. Is this the only licensed vaccine? Because if I recall, the adenoviral vector vaccine is much less reactogenic. So I was wondering why we're discussing this one.
Yes, thank you for that question. Yes, the current Rvsd vaccine is currently the only licensed Ebola vaccine. Over.
And so I guess usually because the company goes to the FDA and the FDA approves the vaccine and then we get to make recommendations on it. But because it's less reactogenic, are we encouraging that vaccine to go on licensure? Or if we did have an outbreak or cases in the U.S., is that something that could be used under EUA?
So, currently the Rvsd Merck vaccine is the only one that's licensed. With regards, there are, as you mentioned, other vaccines that are in development. In particular, the Johnson & Johnson the vaccine has also been used overseas in the setting of outbreaks, but it should be noted there are several differences between these two vaccines. First of all, the Rvsd vaccine, the licensed vaccine that we're discussing today, it is a one-dose vaccine. So after one dose, within a period of time, people are considered to be protected against infection with Zaire Ebola virus. With the Johnson & Johnson vaccine in particular, the MVA adeno, it is a two-dose vaccine, and the two doses are administered 54 days apart. So in terms of outbreak response and immediate, vaccination regarding a response, the Merck vaccine is a little bit more amenable to that because it is a one-shot vaccine. But I do know that the approval processes are continuing for the other vaccines, as you mentioned.
Thank you. And just to confirm, though, we are not talking about outbreak response. We're talking about pre-exposure use.
Exactly. Yeah. So currently, we are talking about pre-exposure vaccination. Thank you.
Thank you. Dr. Fink, did you want to add any clarifications?
I think the previous comments covered some of what I was going to say, but just to note that there are regulatory mechanisms that could allow for access to investigational Ebola vaccines, including for pre-exposure vaccination. And these mechanisms include use under IND, including expanded access. Thank you.
Dr. Zahn.
Great. Thank you, Dr. Lee, and thank you for these presentations. Actually, my main question was answered, which is, are we strictly talking about pre-exposure? But I do have just one comment from a local public health perspective. If I go back to the 2014 and 2015, when there was a large West African outbreak of Ebola, in Southern California, I'm in Orange County, in Southern California, we had a small number of facilities that were really Ebola treatment facilities. That means if they were confirmed to have disease, someone was confirmed to have disease or really seemed to have symptoms that were really consistent with Ebola and had an exposure, they'd go there. We also had, at that time though, because there were so many travelers, a lot of assessment hospitals, meaning you're not a facility that's able to treat from beginning to end a patient with Ebola, but you'd be willing to accept a patient with Ebola with symptoms who had a potential exposure while the initial assessment went on. So the patient would be admitted, they'd go to the emergency room, they'd sit in that emergency room for a few hours, presumably until lab work came back and got some sense of whether they were at risk or not. If they were, they'd go on to the treatment facilities. The assessment facilities were always an extremely difficult conversation. Hospitals don't want a potential Ebola patient, and even if it's extremely low risk. So anybody has at that time, they came back from West Africa and had a low-grade fever. Nobody wants to see that patient because there's just such an infection control risk associated with that. So, my general comment would be if we ever went back to that model again, just imagine it'd be a difficult conversation to talk about why treatment facility staff get the vaccine and others do not, and the pressure would become even more at that point than it was already in 2014, 2015, which is facilities say, we don't want to see these patients at all, just send them to the treatment facilities, and the treatment facilities didn't have the capacity. So I don't know if what I'm saying makes sense, but and your plan makes sense. I totally get you don't want to offer vaccine to a large proportion of people who are very low risk, but it is an issue that I just anticipate in terms of messaging if we get back to an event like that.
Yes, thank you for that comment. Yes, you're absolutely right. The issue of access to vaccine to assessment hospitals has been raised within our work group. in terms of the priorities for our work group, we did try to focus on the individuals who we were perceived to have the highest occupational risk. So, which is why the initial recommendations were for the federally designated ETCs, the LRN facilities, and responders to an EVD outbreak. And so we're continuing with that with the current discussions about the special pathogen treatment centers and the LRNs. But, the conversation about assessment hospitals has been raised several times within our work group, and I'm assured that it will be on the topic of future agendas. Over.
Those comments, very appreciated. Thank you.
Thank you. I actually have a question, which is, I noticed on the acceptability, and I'm assuming these are people who are, intending to care for Ebola infected patients, it was still sort of 54 to 59%. Can you comment on the people who did not find it acceptable to receive a vaccine and the reasons why?
I will go ahead and ask Ms. Amy Weitzel to comment on that.
Sure. Hi. Yes, I can comment on that. So we did ask as a part of the vaccine acceptability survey for those who did not want to receive the vaccine. We did ask them why they would choose not to be vaccinated. So for the special pathogen treatment centers, the two main buckets essentially of responses was a low risk of exposure and concerns about vaccine safety and the long-term effects related to vaccine safety.
Yeah, I mean, it's interesting because the recommendation doesn't specifically include timing too, because your acceptability goes up, obviously, if you know that you have an influx of patients coming in. So I wonder if the recommendation, I guess I'll ask the same question. Should it be shared clinical decision-making to make it broader and more less restrictive? And or should there be a little bit more clarification around, when is the optimal timing? Because clearly you want to maintain that protection also.
Yes, thank you for that question. I think that, as Amy mentioned, for both our questions, when we asked them, would you be willing to receive the vaccine today? The word today was important because it really had to do with perceived risk, really. And for the most part, for both groups, when the vaccine was administered, there was essentially no Ebola cases happening. And so, I think at that point, people are probably weighing, the risks and benefits. There is no Ebola outbreak in the world, which means short of, occupational exposure, they're not going to get a case. But at this point, if I get the vaccine, maybe I'll have some arthralgia, maybe I'll have some of these other effects that we've been talking about. I think at that point, then the balance of the consequences kind of swings back and forth. I think the question of shared clinical decision-making versus recommendation was discussed very robustly within our work group. I can give my initial gestalt, and I could, again, also pass on to Dr. Wilbur Chen, who is our chair. But I think in general, what we felt was that we were looking at, is this population at risk, and does the vaccine protect? And so for both, we felt, yes, this population is at risk because of the definition of their jobs, and the vaccine efficacy is clear. And so based on that, I think is what propelled the work group to lean towards recommendation. But I will maybe ask Dr. Wilbur Chen to see if he would like to add anything. Over.
Yeah, so I think that in addition to that discussion, which again, we revisited this question over and over numerous times. And I think in the back of our minds was, again, could this be perceived as a vaccine mandate by the facilities? And we clearly sided on knowing that our decision, whether it's shared decision-making versus a recommendation, was not to be interpreted by any of these facilities as a mandate or how they would implement the vaccination. So we really tried to concentrate on making our decisions on the strength of whether we thought vaccination was protective to a population that would be at risk. And so are they at risk? And because of the occupations that we identified, we thought, yes, these are people at risk rather than for the general population. And then what is the strength of us believing that the vaccine would be protective? And so we felt that that was also affirmative. So that's in sum how we came about in the work group discussion.
Thank you. I'm sorry, I'm just going to say one last thing, and then I'll turn over to my colleagues, which is procedurally, like, I think there's two ways I could think about how to approach this. One would be the full rec versus shared clinical decision-making. And per our conversation yesterday, I don't believe the fear of mandates should be driving our decisions, so I agree with that. The second is that I would say, like, it would be really helpful to have sort of timing considerations in the clinical considerations document. So this is a recommendation, but this is when the timing might, like when there is an Ebola outbreak or this number of cases or what we, whatever it is, some threshold to give people a sense that your risk is, like when we have 0 cases, it's fine. If we're having outbreaks and we anticipate an influx of patients or travelers or whatever, then giving people the rationale and the clinical considerations, I think would help people feel very comfortable with that. I'll move on to Dr. Daly.
I'll put my hand down because the question I had was what you just said, Dr. Lee. So thank you.
Oh, thanks, Dr. Daly. Dr. Paling.
I wanted to say thank you for explaining some of the conversations about the shared clinical decision making. One of the things that I'm thinking about is there's many women that are in healthcare in the laboratories. And one of my understanding is to say that you're not going to get pregnant in 2 months, within 2 months of getting the vaccine. To me, that is a shared clinical decision making because there's a lot involved and not all pregnancies are planned. And I wanted to understand further about the work group's discussion on that point.
Yes, thank you for that question. So I guess I would, again, echo Dr. Chen's statement that our work group really was trying to focus on recommend versus shared clinical decision making based on is the population at risk and is the vaccine protective. I think, some of the things that made us a little bit, let's say, more reassured is that, this vaccine is licensed at this point and is available through the strategic national stockpile. And for quite some time, and we have been reached out to by various healthcare facilities such as federally designated treatment centers. And so we actually did go to NETAC, which is basically a collaboration of several federally designated Ebola treatment centers. And we did ask them, now that this Ebola vaccine is licensed, is there any thought within your organization of mandating this vaccine now that it is licensed? And, one of what they had said to us was no. And similarly, we had conversations with the LRNs because we wanted to get a sense from them whether or not, now that the vaccine is licensed, was there any thoughts within the LRNs to mandate the vaccine? And again, the answer was no. And partly it's because, we want the testing, the Ebola testing, to be as widely available as possible because it is in the best interest of the patient. Because 9 times out of 10, the person who's suspected of having Ebola does not have Ebola. However, in order for that testing to happen, if that specimen must come to CDC, and CDC is the only place that specimen can be tested, there can be delays, based on when the case is suspected, in terms of shipping, is it a weekend? Is it a holiday? Can we get FedEx or, whatever to deliver it here? That can be an issue. And the longer that they're not able to get that specimen tested, the longer that patient is under Ebola IPC procedures, which are rather strict and can limit the level of care that they receive. And so because of that, we want this testing to be as widely available as possible, in particular at the LRN. So if there are 58 facilities that currently can test for Ebola at the LRNs, we want to keep that number at 58. We don't want to make it lower. And they also agreed with us on that. So I think some of that, did help, our discussions. I think that with any vaccine, it is a shared clinical decision making, because the patient, the person who works at the hospital, let's say at a special pathogen treatment center, has to discuss this with their physicians. Is this vaccine right for me, given my current health conditions, given my current status? So I think all decisions with regards to vaccines, in that sense, is shared decision making with the clinician. But again, when we were talking within our work group, it was the issue of focusing more on whether the vaccine is protective and whether the population is at risk.
Thank you. Dr. Bell?
Thank you. And I wanted to thank everyone on the work group and the CDC staff for working so hard on this issue and, sticking to it and answering some of the pivotal questions. And I certainly think that, we've got a lot more clarity than when we started out trying to think about what to do about this vaccine. I would like to, however, just say give my own opinion about this issue of shared clinical decision-making, or some other way to indicate a may versus a should. And that's primarily because I think that the level of risk is extremely variable. As you know, the definition of healthcare provider is very, very broad. And in that population, I think that just going with the work group's thinking about, is the population at risk? Well, there's a huge difference in whether the population is at risk among those healthcare providers. And second, there's this question about timing that Dr. Lee brought up. And when there's no Ebola, the population is not at risk. And the third thing I wanted to raise in this particular around this issue is that there's a lot of turnover in the relevant healthcare providers, as you know, because you got most of the relevant information for us. And again, I think that also argues for a lot more flexibility and individual tailoring than one might otherwise imagine. And finally, I think from your surveys that there's a lot of differing opinions among the target population about whether they want to get vaccinated or not. And the vaccine is not without side effects. And again, I think it would be useful to facilitate the kind of individual decision making that a recommendation which is not should, but is may, or shared clinical decision making, or however we want to do it, would be helpful. So that's my 3 cents on the subject.
Thank you. And because our time is nearing its end, and there's still a few more hands raised, I'm going to ask, whether or not people have a particular leaning towards the vote language, because I think that would be really helpful so we can get towards the vote. So feel free to raise your hand again or a comment. So Dr. Chen.
This is, I guess, to clarify upon some of the comments. And I think, again, these are comments that we heard and tried to deliberate upon within the work group. So these all are comments that, again, we had taken into consideration. One thing I wanted to mention was that, we fully recognize that that this vaccine would be really implemented at the local jurisdictional level. These are state level rather than federally designated facilities. And so realistically, this would be, and these are not vaccines that are like at the primary care provider level. These are going to be occupational medicine vaccines. They will be managed really by the employee and employer having this conversation. There will be the discussion of the precautions and contraindications sections in trying to decide whether a particular person is vaccinated. And so that's kind of not, again, a reason for or against, shared decision-making versus a recommendation. And I think, again, it's part of workforce management for these facilities. And so employee health will be involved, the employer and the employee will be in discussions again. And so I think that we do have that sensitivity of understanding that the implementation will be very much variable and that there will be low uptake probably in circumstances where there's the perception of very low risk, which we have right now. And then under situations where there's higher risk, there will be more demand. And I think we wanted to have what we called an evergreen kind of approach, which meant that, again, what the decision we make today would stand for situations where there were an Ebola outbreak, even in the US, if that were to happen. And so again, we needed to have a recommendation that stood that test of time. So I'll stop there.
Okay, thank you. Dr. Talbot.
I'd like to include shared clinical decision-making into the vote.
Thank you. Dr. Kane. Dr. Kane?
I'm sorry, I forgot to unmute.
It's okay.
So if I get this vaccine and I have transmission of the virus in my bloodstream for so long and in urine and other parts of bodily fluids, what's my transmissibility of this virus to other people that may be living in my household? And how long should I have to be isolated from members inside my household? Would I be concerned about that? I may have a pregnant wife that's in my household. So what kind of counseling or recommendations are we making related to this vaccine? And would this be a concern of some of your healthcare professionals?
Yes, thank you for those questions. Certainly, as we talked about, there is PCR detection, in some cases, virus isolation of vaccine virus from various bodily fluids. In the published R&R for this vaccine, we do list several precautions that should be taken with regards to, donating blood, in terms of close contacts with, high-risk individuals such as pregnant people, immunocompromised individuals. And so those recommendations are spelled out in the R&R, and there are, precautions that are put in place that are recommended to prevent potential transmission of vaccine virus. Again, those studies are ongoing in terms of evaluating the actual risk of vaccine virus transmission. Those studies are ongoing. And at the time that we did the grade in February of 2020, none of that study data was available, which is why we looked at the presence of vaccine virus in various bodily fluids as a surrogate for potential risk for vaccine virus transmission. But some of the recommendations in terms of, making sure that transmission does not occur is spelled out in the R&R.
Thank you.
Ms. Bata.
I am more in support of clinical decision making, and I'm just wondering if there's a way. I know this was discussed before, but to frame the recommendation that the recommendations in place if local and federal authorities deem an increased risk for Ebola, just because I think people are really worried about where this is going to lead in terms of healthcare. And even though we're seeing a majority of individuals saying that they would get the vaccine, there's a large minority that is really pushing back. And I think we need to be sensitive to that.
All right, thank you. I'll just, sorry, I don't know why I have so many opinions about this one, but, go ahead.
Just two little small points that I just wanted to raise that may not have been clear. Because the vaccine is reactogenic, and because of some of these, arthralgia, arthritis issues, some of which happen a week after vaccination, and the fact that the profession types that we're talking about is very manual in terms of, using your, like if you're a laboratorian, you need to have good dexterity of your hands and stuff like that. And the arthritis that happens and has been reported can be in all joints, small and large. It is not exactly amenable to just-in-time vaccination. Meaning that you would, and also because of the, we want to make sure that you're protected before you actually have the exposure. It is also very difficult to predict when Ebola outbreaks are going to happen. And I mean, I don't want, if, going back with Ebola, back in the day when we would have Ebola outbreak, it was primarily thought to be, zoonotic transmission from animals to humans. However, if you look at the last 3 outbreaks that have happened, based on the genetic sequencing, it's been all potentially linked to persistence in survivors. So now we have potentially, a risk of transmission of the virus from animals to humans, but then from, prior infected individuals, of whom, who have survived the infection, of whom there are tens of thousands, as now potentially also a potential source of outbreaks as well. So, some of this, there's a little bit of unpredictability. Will the number of outbreaks that we have of Ebola increase? But also it's very difficult to then predict when they occur. And so I think, and then on top of that, because of the reactogenicity and making sure that they're protected, it's not something that you want to vaccinate someone and then put them on a plane and send them to Congo, to respond to an outbreak. So it's not really amenable to that short, just-in-time vaccination. So I just wanted to put that out there. Thanks.
Thank you. Dr. Talbot.
Yeah, I appreciate it's not an immediate fix, but I do think you're going to have a pocket of people who are willing to get vaccinated, and those are the ones who are going to be frontline until everyone else's vaccine kicks in. I think that's fine. I think the fact of the matter, though, it is reactogenic. And we don't have Ebola in the U.S. So I think balancing the risk-benefit is a little bit different in this situation. I think if the vaccine was less reactogenic, had less risks, we'd be more willing to do that. So I think that's the issue. And so there are people who will get the vaccine and they'll be our front line, and I'm comfortable with that.
Thank you, Dr. Talbot. I just want to echo one question and then a couple points. So number one, or one comment, I will say, I think the challenge I'm having is that I can get behind a recommendation for the reason that Dr. Talbot says, but I feel like there needs to be stronger guidance from perhaps CDC around thresholds for concern. And, I think of it as like the red, orange, yellow, green, kind of like we do with COVID-19, and thinking about what is the threat level to these treatment centers or to these laboratories. And I don't know what the volume of laboratory tests you're processing through these 58 centers is. Is it like tens of thousands of tests for processing, or is it hundreds? And then similarly, what's the volume of patients we're processing that are getting evaluated now? Is it like thousands, or is it like a dozen?
I mean, if Julie Villanueva from the LRN is on the line, I would defer to her. But, from my understanding, I mean, from patient-wise, in terms, because we get all the clinical consults, if there's a physician in the United States who feels that their patient has Ebola, they will call us. The consults are not frequent. During an outbreak, certainly they pick up. Maybe a week, one a week. Maybe two a week, but certainly the numbers are not large. For clinical consults for suspect Ebola patients in the EVD in the U.S. I vaguely remember Dr. Villanueva mentioning that the number of tests for suspect Ebola is also not particularly high. I think it was in the hundreds, but if she's on the line, it would be good to verify. So if that's helpful.
Are you on the line? Okay, well, in case your colleague is not on the line, the other, so given that, again, I think if there is a centralized process that area that takes on these calls, I think, again, giving all of the laboratories a sense of the threat assessment would actually help people understand what their risk is, and that would help drive vaccination rates. The second would be and again, I agree with Dr. Talbot that if there were no side effects, I wouldn't be concerned in any way. But given that there are side effects that are known, are you going to provide recommendations that it's covered by workers' compensation? Will it be covered by VICP? Because I think it's really important to make sure that these workers, if they are getting a vaccine and have some side effects that impact their activities of daily living, that we give them the opportunity to make sure that they are covered.
Yeah, I don't have visibility on. I'm wondering if any of my colleagues, Dr. Casaboom, or might know, or maybe perhaps Dr. Collier.
This is Melinda Wharton. Is Dr. Mary Rubin on from HRSA?
I'm here.
Dr. Rubin, would use of Ebola vaccine be covered under the countermeasures compensation program?
So the Ebola vaccine is part of the countermeasures injury compensation program. There is a PrEP Act declaration in terms of the specifics and the specific population. So I'm not completely sure in terms of, there's different specific populations that are covered, so that would need to be checked. But I guess the bottom line, my answer would be that Ebola vaccine is covered under CICP.
Thank you.
Thank you. Yeah, and just to make the point that if people have to miss work, just like we did for COVID vaccines, it'd be nice to provide that guidance to facilities so that they are covering individuals if they are receiving the vaccine. Okay. Any other questions, concerns, comments? Okay, I don't see any additional hands raised. Do you want to move to the proposed policy options quickly? Yes, thank you. Dr. Casaboom, are you presenting the policy options? There we go.
Hi, yes, everyone, I'm here. So I know this discussion of the policy options is already underway, but to continue the discussion, and we can revise the language as needed, of course, but we'll go ahead and move forward with discussing the policy options under consideration for the expansion of the use of pre-exposure vaccination with the Rvsd Ebola vaccine in personnel working in special pathogen treatment centers and in facilities within the laboratory response network within the United States. So for background, and as alluded to by Dr. Chen earlier, the ACIP Ebola vaccine work group has had robust discussion on the potential implications of an ACIP recommendation. And as with any other employee health-related vaccine, it's the work group's expectation that this will be implemented based on an institutional occupational health policy. Next slide. The first policy option under consideration is, should pre-exposure vaccination with the Rvsd Ebola vaccine be recommended for healthcare personnel involved in the care and transport of suspect or confirmed Ebola virus disease patients at special pathogen treatment centers? As Dr. Choi mentioned earlier, the majority of voting members of the ACIP Ebola vaccine work group were in favor of the following text. Pre-exposure vaccination with the Rvsd Ebola vaccine is recommended for healthcare personnel involved in the care and transport of suspect or confirmed Ebola virus disease patients at special pathogen treatment centers. Next slide. The second policy option under consideration is, should pre-exposure vaccination with the Rvsd Ebola vaccine be recommended for laboratorians and support staff at Laboratory Response Network or LRN facilities that handle specimens that may contain replication-competent Ebola virus, species Zaire Ebola virus, in the United States? The majority of voting members of the ACIP Ebola vaccine work group were in favor of the following text. Pre-exposure vaccination with the Rvsd Ebola vaccine is recommended for laboratorians and support staff at Laboratory Response Network facilities that handle specimens that may contain replication-competent Ebola virus, species Zaire Ebola virus, in the United States. Next slide. And here's the same definition of healthcare personnel for your reference. Next slide. And with that, I will go ahead and turn it over to the Executive Secretary and ACIP members for continued discussion on these two policy options under consideration for a vote today. Thank you very much.
Thank you. And I just want to pause for a moment and ask if the work group leads and chair would like to take any of the... Are these the proposed votes you would like to go with? Let me ask it that way.
I mean, I would say yes, because that was the decision of our work group. And so we want to be faithful to their votes. And so, yes, I would say these are the words that we would go with.
Okay. All right. Thank you. So can we go back to vote number 1, please? Okay. So these are the two proposed votes with their language associated. So the proposed text was read. I would need a motion for this vote number 1. Dr. Lair.
Move that we accept the proposed text for this vote.
Okay, thank you. Is there a second? Dr. Alt?
I will second the motion.
Okay. Great. It's been moved and seconded that we accept the language for vote number 1. We'll move to vote number 2. Dr. Paling. Oh, Dr. Paling, did you have a question on vote number 1?
I'll hold off. I am out of order. My apologies.
Okay. All right. We'll move to the language on vote number 2. Would anybody like to make a motion for the language on vote number 2 listed on the slide? Dr. Lair.
I move we accept proposed text and for vote number 2.
Thank you. And do I have a second? Dr. Alt.
I will second the motion.
Okay. So it's been moved and seconded that we accept the language for vote number 2. Dr. Paling, did you want to make a comment or ask any questions? Dr. Paling.
I wanted to propose an alternative.
Okay.
That all of these recommendations be as part of shared clinical decision making.
Thank you. Yes, that was my question, and I think I personally see that as a different motion and not an amendment to the current votes that are proposed. So what I would propose is we take these to full vote. If these votes do not pass, we will ask the work group to reconsider the language for a different vote that incorporates shared clinical decision-making, and then we can handle it at that moment. Would that be acceptable, Dr. Paling?
Sure.
Okay, thank you. And we actually need to pause now. So thank you very much, everybody, for your input on the Ebola vaccine session. We thank our speakers for their excellent presentations, and we would like to be able to move on to public comment. I'm going to ask that we just take a 2-minute break. Oh, 5-minute break. Okay. We're going to take a 4-minute break, and we'll be back at, let's see, I can't count. What is that? 47 after the hour. And we will go through public comment, and then we will come back for our votes. Just a warning, so you have 4 minutes now. We may go straight to the votes right after public comment. Thank you.